delaying much. So let me welcome delegates and the internationally acclaimed speaker who is going to talk to us now, Dr. Vignesh Raja, and welcome Dr. Jagdish Rana, who is the co-chairperson, and we are awaiting Umesh might join. And this is, let me introduce Dr. Vignesh Raja from Australia. He is Dr. Vignesh Raja, consultant ophthalmologist and vitreoretinal surgeon in the Charles Gardner Hospital and Joondalup Eye Clinic. He is also the head of the Department of the Ophthalmology at the Sir Charles Gardner Hospital. Dr. Raja took his primary medical degree in India and completed his 3 years master's in ophthalmology from the world's largest eye care system, the Aravind Eye Care Hospital and Postgraduate Institute of Ophthalmology. He pursued further higher specialty registrar training in ophthalmology, the United Kingdom at Liverpool and Oxford from 2004 to 2012, followed by fellowships in glaucoma and vitreoretinal surgery. Dr. Raja moved to Perth in 2013 to do his second fellowship in medical and surgical retina with Professor Ian Constable at SCGH, that is the Sir Charles Gardner Hospital, and the Lions Eye Institute, Perth. His areas of expertise are complex cataract surgeries, glaucoma, medical and surgical retina. Dr. Vignesh Raja has extensively presented in international meetings, published peer-reviewed articles, authored book chapters and a textbook, Constable and Lim Color Atlas of Ophthalmology. Today, he has been very generous, and we are grateful to you for allotting your time during our state meeting, which is happening on Friday, Saturday, Sunday in Calicut, Kerala. And this will be a great opportunity for the delegates to listen to your today's talk on iris implants. Over to you, Dr. Vignesh.
So, Menu sir, thank you very much for your kind invitation. And I still remember the days when you trained me at Aravind Eye Hospital 20 years ago. And thank you very much. It's a great honor and privilege to be presenting at the annual meeting of the KSOS. Let me just share my slide. So can you see my slide?
Yeah. Yes, it's fine. Yeah.
So today I'll be talking on artificial iris implantation techniques. Initially in my practice, I used to think there was no role for this, because we could always get away with pupilloplasties or, or iris resuturing. But then confronted with a couple of blunt eye injury and penetrating eye injury patients, I thought there is certainly a role for artificial iris in post-trauma reconstruction of these eyes. So what I've been using is a human optics artificial iris made by the company of the same name, the Human Optics, which is a biocompatible silicone polymer. And this is foldable. It comes in a total diameter of about 12.8 millimeters, and it's got a fixed pupillary aperture of 3.35. So it comes in, the artificial iris comes in two models. One is a fiber-free model, and another one is with fiber. So the fiber-free model is mainly for either the sulcus placement or capsular bag placement. You can place it in the sulcus or within the capsular bag, and you can do it through a sutureless implantation through the normal phaco wound of about 2.8 to 3 millimeters. And it comes with an injector that you can inject as well. And to place it in the sulcus or the capsular bag, the size that we have to refine this to is about 9.5 to 10 millimeters. And if we are placing in the sulcus, we have to do an iridotomy, with, which we can do with the scissors. But with the model with fiber is used for suturing it to the sclera or IOL with sutures, because it has fiber meshwork to increase the strength. This is not injectable, so we got to fold it, and the wound size is about 3.5 to 4 millimeters. And for the sizing of this, we have to measure the white to white of the cornea and minus 0.5 millimeters from that, so that to prevent buckling of the material, and it's nice and stretched out and covers the pupillary margin nicely. And you can either use 9-O-Prolene or Gore-Tex sutures. So the iris can be implanted either in the bag, in the sulcus, or scleral fixation with Gore-Tex or polypropylene. I prefer to use Gore-Tex sutures because you don't want late breakages with polypropylene later on. Or you can also use an iris IOL complex fixation using Gore-Tex or the Yamane technique. I have a few videos to show all of you, so let me go on to these videos. Okay, and all these are post-trauma eyes. So this is a case where this patient's got, this is his fixed dilated pupil like this, with the dense cataract. And, I thought the pupil was too big to do any pupilloplasty because this is the normal size of the pupil, even undilated. This is the pupil. And he's got a dense cataract there. Here I'm planning to implant the capsule. It's in the capsule bag. So you don't want to make it too big nor too small, because as you get capsular phimosis, then you don't want it to buckle the material. So I'm using Callisto guided 5.5 millimeter, rexus, so that we can get a nice circular rexus to implant it in the bag. I still do good old divide and conquer or stop and chop. I'm not a fancy chopping surgeon, so I proceed with straightforward cataract surgery. As you can see, the cataract is quite dense. I just sped up the video because in India, I'm sure we do much more complex cataract surgeries than these. So, I'll cut to the chase straight right now. So all we need to do is nice thorough IA with cortical cleaning, and then we prepare the bag for lens implantation. So here we fill the bag nicely with viscoelastic. And to stretch the bag, you put a capsule tension ring because you want the bag to stay as expanded as possible. So I've injected the capsule tension ring, and here goes the toric intraocular lens. So you can see the rexus margin overlapping the lens now. And here is the fiber-free artificial iris. So this comes in standard brown, in a standard brown color, or you can make it custom made compared to the patient, compared to the patient's fellow eye. So here's a Trifine. So you press with the Trifine with the Moofield's forceps on the top so that you get a nice ring all around. And here I'm injecting, the other side of the iris prosthesis is just dark black in color. So here I'm injecting it into the injector. And I'm expanding the capsule bag nicely. I'm just making a second side port so that I can use an MSD or max grip forceps to unfold it. And then with the mushroom or a second instrument, I tuck it into the bag. So this is the fiber-free version. You can either stick it in the sulcus or in the bag. I chose to put it in the bag in this case. So cosmetically, it looks pretty good. And when patients have brown iris, so it actually matches the other eye very well. The price of the standard brown one is about $2,000, about 1 lakh rupees. The custom made one is about $8,000, where they take photographs of the other eye and do it. So that's roughly about 4 lakh rupees for the other eye for a custom made prosthesis. Now going on to another case.
Vignesh, can we discuss a little about the first one, because when we finish off, we don't remember all these things. Is that okay?
Sure,
We have time, no problem.
Yeah, sure.
No, the first case, there was iris all around, is it not?
There
is iris all around, and just because it is fixed pupil, you wanted to reduce the size of the pupil.
Correct.
Yeah.
because
So,
this patient had a severe glare.
Claire, yeah. So you implant the IOL first and then this one, is it?
Correct. Correct.
So this has to come over the IOL. So
Over the
have
IOL.
you ever tried putting this one first and then getting the IOL into the bag?
No, the problem with that, sir, is the aperture of the pupil is fixed at 3.3 millimeters.
Okay, okay. So it'll be difficult to
because
get
of
get
that,
this IOL in.
yes. So because of that, you want to put the IOL first. You want to put the CTR first. If you're putting it in the bag, you want to put the CTR first to expand the bag.
Yeah,
Then
yeah.
put the IOL and then put the iris prosthesis on top of it.
Okay, and you refined it to what size did you refine it to? 9 point?
I defined it to 10 millimeters.
10 millimeters. Okay.
Yeah.
So do you change it for any, in large eyes or myopic eyes, it has to be different,
Correct.
anything like that?
Correct, I do.
Okay.
So what happens is, for capsular bag placement or sulcus placement, 10 millimeters should be a standard size, should be enough. In fact, here, this model, I could have even placed it in the capsular bag, but I thought in the sulcus, but I just chose to put it in the capsular bag just to try something different.
Okay, so that will remain just behind the iris, supported by the remnants of the remnant iris already, which is there. Okay.
Correct, correct, and resting on the anterior capsule.
Do they provide this in India also? Can we order from India also?
I think so, because the company that supplies it here is called Spectrum Surgical or Human Optics, and there are now a few other German companies that are producing this as well.
Morcher kind of people?
Not Morcher. It's mainly Human Optics.
Okay.
Yeah.
Okay. Yeah. We'll carry on.
Yeah. So I'll go on to the next case. Now, this case. Here you can see that there is no iris whatsoever. This patient had a penetrating eye injury, and in fact, he lost all of his iris completely. So here he had quite a high astigmatism of about 4 diopters of astigmatism. So what I'm planning to do is to scleral fixate a toric intraocular lens, and then on top of it, use an iris prosthesis as well. Let me just go back to the video. So what I'm doing is I'm making a peritomy there, and I'm marking, I've marked the toric marks here. Let me pause the video. So these are the toric marks, the implantation axis of the toric. And I'm just going to mark 1.5 millimeters from the limbus and 3 millimeters from the limbus. So 1.5 there and another 1.5 in the back. So I've inserted the vitrectomy trocar cannulas, and I'm just doing a thorough core and peripheral vitrectomy. So here I'm actually scleral fixating an Envista, a Bausch & Lomb Envista toric intraocular lens with Gore-Tex. I amputate the haptics off.
This is a 23 gauge forceps?
This is a 25 gauge max grip.
25.
We could either use MST 23 gauge max grip or 25 gauge max grip. So I'm just using a 25 gauge because then the sclerostomies are quite small.
So now you have passed these two through that to the 1.5 and the 3 millimeter sclerotomies which you have created.
Correct. And I pass it through the eyelet on the Envista lens.
Yeah.
And I'm just suturing it using a sliding slip knot. So this is a good case to implant a toric lens, you know, when we have to scleral fixate a toric lens.
So
but
through
we
a
always
25 gauge, this knot goes in through the 25 gauge, is it?
It goes in very nicely. So yeah, okay. And what we have 25. To do is we have to make sure that we actually rotate the knot into the eye. Otherwise, it will cause a melt of the sclera and conjunctiva around, if you leave the Gore-Tex knot exposed on the surface.
And how do you prevent tilt of this lenses? Sometimes when the haptics are not there, and when you tighten, if it is a little too tight, this lens twists or tilts. So adjustment, yeah.
So that's why we use a sliding slip knot, you know, because when you do a sliding slip knot, you can adjust the tension on both sides before you lock the suture off.
Before, okay.
So it's a 1-1-1 sliding slip knot. And now
first
what I'm doing,
first one and second one in the same direction, and the last one to lock it.
No, sir. No, first one is a normal cross. Second one is where the suture goes over the needle holder. Not the needle holder does not come within the throw. It comes above it. Like how we, you know, like how we lock the last suture, we do it as the second step.
Okay.
And now what I'm doing is I'm going to now do another sclerotomy, you know, 2 millimeters from the limbus, but 4 millimeters apart, so that then I can put the artificial iris with the fiber. So what I'm doing is I'm measuring the white to white, the vertical white to white, and you minus 0.5 millimeters from that. And then again, we have to take, you know, make sure that we press the trephine with the move fields, so that you don't get, you know, you don't get a cut which is haphazard there. So now I'm passing the CV8 Gore-Tex suture.
This is a 7.0 Gore-Tex.
7.0 Gore-Tex, yes. So you have to make sure that you're at least 1 millimeter from the edge, because you don't want the suture at the edge. And I use the boundary of the pupil as a guide. And likewise, I do the same from the other side. Again, it's all a 25 gauge max grip. And you can actually see the toric lenses along that axis very nicely. And this one, we can just fold it, and we have to extend the wound to about 4 to 4.5 millimeters. The only thing with this technique is you see these two white lines, you know, there, but I think, you know, after what the patient's gone through, that should, you know, that should be fine. And I'm just closing the conjunctiva with glue. So any questions from this case?
This is fantastic. This is fantastic skill. So only thing is, why did you go 2 millimeters and why did you go 3 millimeters for the other one? So I have seen people go from the blue-white junction, 1 millimeter behind that, and then 1 more millimeter, or even you usually go vertically 1.5 and 3 rather than the same 2 millimeters on adjacent to each other. That you don't do for the sutures like this. What you did for the this one, the iris implant.
This one I did 1.5 and 3. Normally, when I do Gore-Tex, I do 2 millimeters. Now I do 3 millimeters from the limbus, and 2 sclerotomies 4 millimeters apart. 2.5 to 3 millimeters from the limbus, 4 millimeters apart. But now, when you're doing a scleral fixation of a toric lens, you want the suture to line up with the axis. You know, so that's why I do 1.5 and 3 radially rather than along the limbus.
Yeah, that is perfect.
Yeah. So now I'll go on to the next case.
Now, how long follow-up do you have for that case?
These cases I have 6 to 9 months follow-up now. You know, I started doing this only in the last 9 to 12 months.
Okay. Yeah, we'll see the next.
Yeah. So this is a case where, again, injury with just, there is no lens, penetrating eye injury again. There's just this strand of iris there. And this was something that I could not salvage with any kind of pupilloplasty or anything at all. So this was my third case. So now what I've done is because I found that the refractive error is much more predictable when you're 3 millimeters behind limbus. So I'm now marking 3 millimeters from limbus, and these marks are, 4 millimeters apart. So 2 millimeters on either side.
So complete vitrectomy has to be done, is it, for all these?
No, sir. In fact, this case already had previous vitrectomy done. This case had previous vitreolensectomy at the time of the blunt eye injury. Okay. He had blunt eye injury, so they did vitreolensectomy, complete everything, but they just left the iris stump like that because they didn't want to mess around. So when they did the primary repair, they did it and then sent it to me for surgery. But so, in fact, we can do this case with AC maintainer very nicely. You don't need a vitrectomy setup at all. But I just set it up as vitrectomy because in case it falls down or things like that, then at least I'm there to I can pick it up at the same time, because I was also learning with these cases. This was only my third case. I'm showing you the cases in the order that I did them. The first case was my first ever iris case. My second case was my second case. This was my third case. So now what I'm doing is I'm actually cutting off that stump, but I have the intraocular diathermy on, on standby, just so that if the iris bleeds or anything, I can use the intraocular diathermy to cauterize the stump. So in this case, I wanted to do something different. So again, I take the Trifine, you press on it with the move fields to get a nice circle here that the iris sticks to the Trifine. And here I'm using a Physiol micropure lens. So all I do is I put a drop of saline, so the iris nicely sticks to the lens. And I'm now passing the Gore-Tex suture through the eyelets, but incorporating the iris also at the same time. The iris and the hole in the haptic. It's something similar to the Acryos AO, but this is a Physiol micropure lens, which is hydrophobic. So I thought because we do vitreoretinal surgery, I prefer to use a hydrophobic lens. So that's why I moved to this platform rather than the Acryos. So now I'm implanting both the Gore-Tex fixated complex of the artificial iris and the micropure lens in one complex. The critique that I would critique myself with this case is maybe I shouldn't have gone 3 millimeters. I should have gone 2 millimeters, because then it will look exactly like 1.5 or 2. So then it look exactly like the normal iris. Because I went 3, I had to pull the sutures a bit tight. And when you look at this patient on the slit lamp, you can see that there is a gap between the his normal iris and the pupil. Normal iris, the remnants, and the artificial pupil. And And here I've again used glue to stick it down. So any questions at all from this case?
No, this all looks so simple and easy with you. I can't believe that it is your second case or third case. Looks so clean. And this basically 3 millimeters means you're close to pass planar. So
I am. In fact, because I was learning on these cases myself, if I had to do this case now, I would go only 2 millimeters from the limbus, because then the iris will sit at 2, the IOL will sit at about 2.5.
Okay. And here there is no need for a iridectomy, is it not? The kind of some opening on the iris, no.
No need for iridectomy, because it's a completely vitrectomized eye, so there is no vitreous to cause pupil block. And second is there is a lot of space for for the aqueous to move around. Because
the edge is always free. The edges are not stuck anywhere, so there will be definitely gap between the edges. Yeah,
correct. So then the next case was my 4th case. So this time I watched Ike Ahmed's video where he did a case of fixating the Zeiss CT Lucia on the Yamane technique to the iris.
Sorry, Vignesh, we will need to stop in 4 minutes.
Sure, sir. Sure. I will play the video very quickly. So I'm marking like the Yamane.
Please carry on. Please talk on. Yeah.
Yeah, I'm marking like the Yamane, and then I'm making a 6 millimeter scleral tunnel. So I won't bore you with these details. So, and he's also got an epiretinal membrane. So I did the vitrectomy for the epiretinal membrane at the same time.
The Yamane marking is 2 millimeters, is it not? 2 millimeters behind?
2 millimeters, yeah.
Yeah.
So both these are 2 millimeters and 2 millimeters. So I'm now bending the needle.
This is a 30 gauge needle?
30 gauge,
30 gauge,
yeah. 30 gauge TSK needle from Japan. So this is a custom-made iris prosthesis. It's made according to the other eye. So now what I'm doing is I'm taking a 15-degree blade, and I'm making 2 slits 1 millimeter apart. And so I'm making a belt loop in the iris so that I can pass the blue haptics through that. Passing the second haptic is slightly tricky because you think the haptic is going to break, but because the CT Lucia lens is so good.
Is the haptic PVDF, or here is it a PVDF haptic or?
PVDF.
Yeah. Then won't break.
Yeah. So now I'm putting this, and I'm securing the wound, and I'm then just doing a Yamane for this technique. Let me just show you. And I've already actually secured the other side, and I've already burnt off the haptic on the other side. And so that's it. So this is how the case looks at the end. And I just sutured the scleral tunnel because it's quite big. So I secured it with the Yamane on both sides. And that's it from my side.
That was terrific. And the first haptic going in maybe would have been little difficult. Is it not? First haptic getting it through the needle?
I will show you that. I'll show you that. So here, it's here. In fact, that's why I put a stay suture there, and I had to use the biome to actually look at it.
The haptic is anterior to the iris processes or posterior?
The
anterior,
haptic is,
no? The tip.
The tip, no, it's actually posterior. I'm deforming it so much. I'm bending it so much and bringing it out to the front so that I can see it and then bring it out there.
Okay, okay. So that means only the part of it in front is you can see because okay, okay, okay. The free part is behind the iris. Correct.
Correct, correct. I just put a belt loop there.
This is a very difficult maneuver. Well done, well
It
done.
is,
It has to be appreciated. It's a highly complicated maneuver.
Yeah, no. In fact, that's why I had a stay suture there, just in case it falls down, so I can cling on to dear life and pull it up. So that's it.
Okay, thank you very much. That was a very good discussion as we could discuss through the case. It was nice to have you and present this complicated thing. People should benefit, but the cost factor is little tough in India, but then maybe they'll charge less in India, maybe. I don't know.
No, the cheaper alternatives are out now. So there are many manufacturers who are coming up with this now. So we should be seeing it in the next year or two quite widely.
The last one, what is the size you refined it to?
I refined it to about I think 10.5, if I'm not wrong.
White to white and reduce it by 0.5 to 1.
Minus 0.5, yes.
Yeah. Okay, after Dr. Jagdish, if we can wind up, you have some final remarks because we are through time.
Yeah, this was excellent surgery done by Dr. Vignesh. Yeah, just one question I want to ask: is there any difference in the surgery if it's a phakic eye without cataract? Your experience with your eye? Yeah.
No, if it was a phakic eye without cataract, then probably better not to do anything at that point. It's better to combine it with cataract surgery, and we can place the iris prosthesis in the sulcus.
Okay. The patient is of young age and having photophobia and no cataract. Yeah.
In that case, because if we put this in the sulcus, it will cause a cataract. You don't know the problems that it can cause. It can cause glaucoma and what have you. Yes. So for them, usually I'd say just use a cosmetic colored contact lens. A cosmetic colored contact lens should reduce the glare. Yeah,
very true, very true. So it was a really excellent presentation, excellent surgery, a superb skill. Thank you so much, sir. Thank you.
No, thank you very much. Sir.
Okay, thank you.
Thank you, Dr. Vignesh. So we'll wind up this session. Thank you.
Sure.